In this video, I'm going to be sharing what the first 4 hours of my normal shift looks like. All right, report for my job starts at 6:45 in the morning. I do work in a hospital. It's a pediatric facility, and I do work day shift. So when I first come in, we already have assignment sheets down where we can pick up our paper, we can look at it, kind of see what our day is going to be. It does have vital signs, any procedures, if the sheet was updated. Just kind of a quick rundown of everyone's patients. So at 6:45, the previous team leader comes in. He or she kind of gives a quick rundown of every single patient on the unit. And you might be thinking, why do we need to know everything about every patient? Well, think about it. Say another nurse is busy and you're not quite as busy. You have a moment you can help somebody. Say someone calls out. They say, I need to see my nurse, which half the time it can be answered over the intercom system or the call light system, but that's neither here nor there. They come, you can go in there. There are very important things that you need to know. You need to know if it's not your patient, so remember, you're not going to get report on them, but you're going to get this brief rundown. Are there crazy social situations that you need to know about? Do you need to know that this kid or adult, whichever facility you work in, has this adult lost 12 IVs in the last 2 days? And so are the parents calling out because they think that their IV might be bad? Like, that's good. You don't just want to let that sit and wait for the next nurse to come, because that nurse could be 30 or 40 minutes before they're available to go into that room. And if their IV has infiltrated, that's 40 more minutes of fluid potentially going into like a baby's arm. And we do not want that. That is the last thing that we want. Okay, so report ends at approximately 6:55, 7 o'clock, and that's when we leave the break room and we want to go out and we want to find the nurse or nurses that we're going to get report from. This lasts anywhere 15, 20 minutes. For me, that's that's not per patient, that's like overall. But for me, that's way, way, way too long. All I want when I get report, I don't need to know that they have Q4 vitals or that they're on a regular diet. Things that are important are even allergies. I mean, allergies aren't that important because I can look those up in the chart. Our interactions can be done really fast. So what do I want to know? I want to know, are we giving pre-meds for a certain medication, antibiotic that we're giving? How often we're getting pain meds, or the expectations that families and parents and patients are having about pain medication administration. Do we have narcotics ordered, but they don't want to use them? They really want to stick with Tylenol and ibuprofen. That kind of stuff is important because that's not really anywhere in the chart. I want to know about any social situations. Is dad, we should have got this information in our group report, but is dad or mom or grandma or grandpa, are they not allowed to be there? Is anyone in the family a registered sex offender? I mean, that kind of stuff does come up, and that's good to know. We need to know if they know what these people look like. Other things that I want to know, is there PIV or is there CVL, their PICC line? Is it positional? Like, in order to get blood out, do we need to like have their arm up in the air, backwards, just a certain way to get blood? Do they, and you might think that these are ridiculous, do they have an arm or leg that is amputated? That's really important to know, especially if you someone going in there first thing. I haven't even seen their charts yet. Are they missing the arm? Are they missing a leg? Am I going to be looking for an IV? Am I going to be looking for an arm band, an ID band? I need to know that. Are they deaf? Are they blind? Things like that, so important. I've been embarrassed before over not knowing that information, because I go in, everyone's awake, and I say, hey, can I see both your arms so I can look at your armband or your IV? And they say, well, we don't. They get real quiet and it's kind of awkward. He's missing his right arm. He got amputated. Whoa, that was embarrassing, and I came out and I was furious. After I get report, I go to a computer, I sit down, and I start filling out my brain. My brain, any nurse's brain, is their paper that they write down everything that they need to do for the next 12 hours on each of their patients. In a pediatric facility, 3 to 4 patients is what's considered safe. So I can typically write everything that I need to on one piece of paper. If you work in an adult facility and you have 8 patients, Leave a comment down below. How do you have 2 pieces of paper? Do you even make a brain on everybody? I don't know how complex that is. I haven't been in clinicals in years. I'm writing down the patient's name, age, weight. I work in peds, and so weight is important for dosing. Their diagnosis, their allergies, the physician team and resident with the pager number, vital signs, weight frequency, location of IV, and what type of fluids are going. When the IV lines are due to be changed, when CVL dressings are due to be changed, their current diet, and any procedures today or coming up in the next few days. So after that, I go to the patient smart and I write down all medications for the day. So home medications, antibiotics, any other IV meds, and then any PRNs. And with the PRNs, I always look and write down when they had them last. And of course, I already have the frequency, so I know when they can have them again. This is also the time I take the weight that we just mentioned, and I make sure that all of my doses are correct and that they're acceptable. So ideally, I can get all of this done by 7:30 or 7:45. This is kind of the moment where I don't really want people talking to me. I really don't want doctors or physical therapists or respiratory therapists talking, because this is kind of my sacred time where I can write down and organize my day. Does it always happen? No. And we'll talk more about that in a few minutes. But if you're interrupted and you don't get to finish this can really, really throw off your day. So this is really, really important. Okay. So then after that, I'm going to look at my brain and I'm going to see there's one of 2 patients that I'm going to see. If somebody is really critically ill, so someone that we're kind of worried about that they might be kind of, circling the drain and we want to intervene, I'll assess them first. Or I'll find the patient that is going to be, in my head, it's going to be super easy, super fast. I can get in, get out, chart, and be kind of done with them in the charting part. As far as meds go, I can't start giving any meds until 8 o'clock. They're typically put in as 9 o'clock meds, and we can do an hour either way. So I can give them between 8 and 10. And I do this repeatedly with each of my patients till I'm done with everything. My goal every day is to get done with all of my charting by 11. Does that always happen? No. Sometimes does it happen like before 9 o'clock? Yes. And that is a great, great day. But it doesn't always happen every day. And this is kind of a rundown of this has a lot of variables. There's a lot of things where it does not end up working like this, which is fine. I mean, life is life. I'm a nurse. I can learn how to adjust to different situations. So there are also other variables that can keep this from happening on time. And that includes phone calls. Phone calls are such a big deal. Or patients calling out needing things. Some things, they can wait. Other things, they can't wait. Sometimes I really wish families would just call out. I mean, there's these are situations where you need to tell us, please. But the phone calls. We get calls from physical therapy, respiratory therapy, doctors wanting an update of how the night went, doctors wanting me to explain why there are no I's and O's charted from last night. I have no idea. I wasn't here. I got here, and you know this. You doctors who do that, which I realize that maybe I know something. Maybe I do know something. I don't know. I never do. If they didn't chart it, I can't go back and chart that. I can always go ask the family, and I can let you know. I can write a note that this is it, but I'm not going to. I have no idea. I wasn't there for the last 12 hours. And I know y'all get there before 6, or you get there before 7. So come on, let's be more proactive. We also get phone calls from different departments that are wanting to know when patient A can come down for their x-ray today, or their CT, or any other surgery. We're going to come down at this time. Okay, great. Doesn't ever happen at that time. Always gets pushed back, which I completely understand. Things happen in surgeries. Surgeries go long. Emergencies happen. We understand that. But it's just lots and lots of little phone calls that really do slow your day down. Also, we have to go to rounds. So our rounds are typically from 9 a.m. to 12 p.m. Ideally, somewhere in there. I love rounds most of the time, except when I'm busy. But it is the best opportunity for you to ask questions about what the plan is for the day. to get information on the plan to involve the families in this is what we're going to do today. And so everyone's on the same page. I love it. And so that you don't sit down later, say that you missed rounds because you were in rooms, which it happens. And sometimes we have 3 or 4 or 5 teams even that come up and do rounds at the same time. So our team leader cannot be everywhere at the same time, and everyone might be busy. So nobody knows what's going on. We sit down at the computer and there's all these orders for these weird labs. And there's just a ton of orders and we don't even know. We're like, why are we doing this? And sometimes the families can't tell us. And sometimes you really don't want to go in there and ask the families those questions because they're like, well, did they not communicate with you? So we have to page all these different doctors. So going to rounds is important. And it's important for the families to know that we're all on the same page. Okay, and so this was I think, fairly brief rundown of what my first 4 hours on my shift look like. It's not always fun, those first 4 hours. Sometimes they're boring because sometimes everyone gets a really good mix of assignments. If you get kind of a crappy assignment, it's over. But no matter what, my piece of advice is don't let your first 4 hours, don't let it ruin your day completely. I would much rather be super busy my first 4 hours than super busy my last 4 hours. That's going to trump everything. So my question for you today is, wherever you work, is this what your day looks like? If not, let me know down in the comments below what it looks like. I know every facility is different. Every nurse is different. Even the people that I work with, they do their day a little bit differently. The thinking that they do is different. And so I really would love to hear that. I would love to know that. Anyways, thanks for watching this video. If you enjoyed watching it, hit the like button. If you loved it and you want to hear more, hit the subscribe button.